Hello everyone, welcome to Roadmap to Residency. I am Abhiraz. Welcome to our Club 250 Matchmaker sessions. We will be running through a question with you guys to help you on your journey to a 250. So here we have a question with us. So which of the following is the most likely cause of this patient's polycythemia? So a 63-year-old woman is hospitalized because of dyspnea on exertion and generalized fatigue. She has been hospitalized 3 times during the past year for heart failure exacerbations, and her other medical problems include essential hypertension for 20 years, myocardial infarction at the age of 58, and hypercholesterolemia. She has a 36-pack-year smoking history in addition to a 10-year history of alcohol abuse. Physical examination reveals tachycardia, distended neck veins, bilateral crackles on lung auscultation, a third heart sound on cardiac auscultation, and pedal edema. The appropriate therapy is initiated. On the third day of hospitalization, her hematocrit level increases to 50%, up from 44% on admission. And arterial blood gas analysis shows an arterial O2 partial pressure of 70 millimeter of mercury. Uh, uh, S1, create an intact red blood cell infusion indicates normal red blood cell mass. Which of the following is the most likely cause of this patient's polycythemia? Polycythemia vera, hypoxic erythrocytosis, renal disease, occult neoplasia, and a relative erythrocytosis. Please pause the video and guess what is the answer. So the correct answer here is relative erythrocytosis. We will go through the explanation now. So whenever we talk about polycythemia, is it when the hematocrit level is more than 48% in case of females and more than 52% in case of males. And whenever we talk about polycythemia, it is generally absolute polycythemia or relative polycythemia. So the relative polycythemia is when there is normal RBC mass in case of dehydration and excessive diuresis. But the absolute polycythemia is when there is true increase in the RBC mass. So it may be due to polycythemia vera, where all the 3 cell lines are increased, or maybe due to secondary erythrocytosis, where only RBC increases and there are normal WBC and platelets. Or it may be due to hypoxia, which can stimulate the erythropoietin producing which can also stimulate the production of erythropoietin. And there are some of the erythropoietin producing tumors like renal cell carcinoma, which can cause secondary erythrocytosis. So in a patient with erythrocytosis, the following tests can help determine the cause. So number one is the absolute versus relative erythrocytosis. So hemoglobin and hematocrit levels cannot accurately differentiate these conditions, and direct measurement of the RBC mass is necessary. An increased total RBC mass indicates an absolute erythrocytosis. A normal RBC mass indicates a relative erythrocytosis. Now, this patient does not have an increased RBC mass and is likely experiencing relative erythrocytosis due to the aggressive diuretic therapy for the heart failure exacerbation. Primary versus secondary erythrocytosis, the serum erythropoietin levels can be used to differentiate the primary from secondary erythrocytosis. Primary erythrocytosis is associated with low erythropoietin levels and is caused by myeloproliferative disorders such as polycythemia vera. Secondary erythrocytosis is characterized by increased erythropoietin levels due to chronic hypoxia from high altitudes, smoking, or COPD disease, or abnormal secretion by neoplastic or other disease tissues. Number 3 is the hypoxic versus other causes of secondary erythrocytosis. A measurement of the arterial oxygen saturation is important to exclude hypoxemia as a cause of the erythrocytosis. Oxygen saturation less than 92% or a PaO2 less than 65 millimeter of mercury can cause secondary polycythemia. Now, SaO2 measured as a percentage should not be confused with PaO2, measured as a partial pressure in millimeter of mercury. The choice A of polycythemia vera is a myeloproliferative disorder associated with marked erythrocytosis and more modest increases in the granulocytes and platelets. A low erythropoietin level is characteristic along with increased RBC mass. Hypoxia is a common cause of secondary erythrocytosis. When the SaO2 is less than 92% or partial pressure of arterial oxygen is less than 65, it appears to be the threshold for the development of secondary erythrocytosis. Now, this patient has hypoxemia above this threshold and acute increase in the hematocrit and normal RBC mass. Now, none of these features are consistent with hypoxemia-induced erythrocytosis. Now, to C and D. So occasionally renal diseases or occult neoplasia can cause secondary erythrocytosis due to abnormal erythropoietin production by the diseased tissue. Now, workup will reveal an increased RBC mass and an increased erythropoietin level. However, chronic renal disease typically leads to the decreased erythropoietin production. But there may be compensatory increase in the erythropoietin after a longer period of time. So let's discuss something about the Polycythemia vera. So these are the malignant clonal proliferation of hematopoietic stem cells leading to excessive erythrocyte production. So the increase in the RBC mass occurs independent of erythropoietin, and the median survival time with treatment is about 9 to 14 years. The mutation in the JAK2 tyrosine kinase are found in more than 90% of the cases. The clinical features may be the signs and symptoms of hyperviscosity, like headache, dizziness, weakness, transient visual disturbances, and dyspnea. The thrombotic phenomena, example, DVT, pulmonary embolism, MI, or portal venous thrombosis can occur. There may be aquagenic pruritus, there may be facial plethora, there may be hepatosplenomegaly, or there may be hypertension. So the diagnostic criteria of Polycythemia vera must have all three major criteria or the first two major criteria plus any two minor criteria. So the major criteria would include the elevated hemoglobin, bone marrow biopsy with trilineage hypercellularity, and a JAK2 or a JAK2 exon 2 mutation. And the minor criteria that the serum erythropoietin level below normal. So the treatment include the repeated phlebotomy, the mainstay of therapy to lower hematocrit, aspirin to decrease the complications, and hydroxyurea for patients with history of thrombosis. So Polycythemia vera must be distinguished from reactive polycythemia. So in a polycythemia vera, the EPO levels are decreased and oxygen saturation is normal. In reactive polycythemia, due to high altitude or long disease, oxygen saturation is low and EPO is increased. In reactive polycythemia, due to ectopic EPO like RCC, renal cell carcinoma, EPO is high and SaO2 is normal. Okay, so you need to keep these things in mind to answer the previous question that we did in this video. So now let's talk something about the essential thrombocythemia. So it is characterized by the massive proliferation of megakaryocytes and platelets and symptoms including bleeding and thrombosis. The blood smear shows markedly increased number of platelets, which may be large or otherwise abnormally formed. The erythromelalgia may occur, and it is associated with JAK2 kinase mutation. It rarely progresses to myelofibrosis and or acute leukemia, and there is no significant risk of hyperuricemia or GOT in case of essential thrombocythemia. Now let's review something from the first aid about the myelodysplastic syndromes. So these are the stem cell disorders involving ineffective hematopoiesis, defects in the cell maturation of non-lymphoid lineages. So the bone marrow blast is less than 20%, whereas it is more than 20% in case of AML, and it is caused by the de novo mutations or environmental exposure like radiation, benzene, or chemotherapy. The risk of transformation to AML is there in case of myelodysplastic syndrome, and the MDS is more common in older adults. So one thing you need to know about is the pseudo-Pelger-Hude anomaly, where the neutrophils are there with bilobed nuclei and is associated with myelodysplastic syndromes and drugs like immunosuppressant. So before we end this video, let's review this chart once. So in case of relative polycythemia, which may be due to dehydration, the plasma volume is low, the RBC mass is normal, oxygen saturation is normal, and EPO is normal. But in case of absolute primary polycythemia, which may be due to the polycythemia vera or JAK2 mutation, the plasma volume is normal, but the RBC mass is increased and the EPO production is decreased. So in case of secondary absolute polycythemia, it may be due to the physiological response to hypoxemia, in which the RBC mass is increased and oxygen saturation is decreased. And it is due to the effect by the EPO. Now, in the case of secondary absolute, due to the inappropriate EPO producing tumors, the EPO is increased and the RBC mass is increased, whereas the oxygen saturation is normal. So this chart will help you answer most of the questions related to polycythemia vera and all. Thank you for watching. Keep studying hard.